So when we talk about lupus nephritis, I told you that the other disease that I want to discuss today is lupus nephritis. Okay, it is a very common manifestation of SLE. 30% have a renal manifestation at the diagnosis itself, and majority of the patient, I told you, around 50-60% of the patient will develop kidney disease, if not at the beginning, usually within the first 2 years. So it is, general. It is a general thumb rule that if the patient does not have any kidney involvement within the first 2 years of SLE, then probably they've escaped. Probably they've escaped. They are in the minority of patients who don't have renal manifestations at all. And SLA, we all know that it is a relapsing and remitting illness. So it comes and goes. So there is need for prolonged immunosuppression in lupus nephritis. You really can't stop. You really don't know when to stop and when the disease will come back. So this is the International Society of Nephrology Renal Pathological Society classification of lesions in SLE. This is a very, very frequently revisited MCQ topic. So let us just go through it. So you divide it into 6 classes. So you do a light microscopy and then you look at the tissue. Different types of damage can be there. Sometimes there is no damage at all. Okay, no damage at all in light microscopy. That is class 1. Okay, minimal mesangial, normal histology with mesangial deposits can be seen. And this is very rare when you catch it very early, that is. And then you have class 2, which is a mesangial-proliferative pattern. So there is proliferation, there is mesangial hypercellularity, the term that we discussed. Okay, that is class 2. And class 3 is your focal nephritis. Less than 50% of the glomeruli are involved, right? Less than 50% of the glomeruli involved. Class 4, more than 50% of the glomeruli involved. So it is a proliferative nephritis. There is endocapillary and extracapillary proliferation and diffuse deposition in the subendothelial space. Okay, in the subendothelial space. Okay, that is your class 3 and class 4. Class 5, there is not much of inflammation, but there is thickening of the basement membrane. Okay, a membranous pattern. Okay, membranous pattern is seen in class 5. Okay, so usually patients do not have not much of creatinine derangement in class 5, but they will have a lot of proteinuria. Okay, they will have a lot of proteinuria. And class 6 is when we've missed the bus, or we've been defeated by the disease, and most of the glomeruli are sclerosed. Okay, and more than 90% of the glomeruli, and when more than 90% of the glomeruli are sclerosed, you call the class 6 global glomerulosclerosis. Okay. Luckily, if you can catch the disease early and treat well, then you might have CKD, but only 20% will develop the end-stage renal disease. Okay, you can get away with CKD in 80% of the patients if you catch the disease early and if you are able to treat the patient well. So the outcomes are good if remission is achieved, that is stable GFR and less proteinuria. So a complete remission is less than 330 milligram per day, but that's like a dream for most of the patients. The treatment consists of an induction phase and then a maintenance phase as well. In induction phase, you go strong, you give high dose of steroids and some, cytotoxic therapy like cyclophosphamide or mycophenolate mofetil, cyclophosphamide or MMF. And then once you achieve, at least partial remission, you maintain the remission with low dose steroids and MMF or azathioprine, okay, which are all and cytotoxic drugs. And if at all, the 20% who do reach kidney disease, if their SLE is quiescent for more than 6 months, they can undergo a kidney transplantation. And lupus, luckily, is not known to recur much post-transplant. Okay. So let us talk about some updates that I found when I read about whatever I talked about till now from Harrison's textbook. There are a couple of things that are new in the 22nd edition, which were missing from the 21st edition. So that is the mention about 2 new drugs which are US FDA approved. Okay, 2 new drugs which are US FDA approved for the treatment of lupus nephritis. Okay, and SLE in general. One is a novel calcineurin inhibitor called Voclosporin. Okay, it is a novel calcineurin inhibitor. Okay, the one that is currently in vogue is tacrolimus, which is the conventional CNI used both in kidney transplant as well as SLE. But here you have a new drug which is supposed to be safer than tacrolimus and as efficacious as tacrolimus. It was studied in a trial called the Aurora Trial. So that's another MCQ point for you. We won't go into the details, but Aurora Trial examined the efficiency of Voclosporin, efficiency and safety of Voclosporin. And the other one is Belimumab. Okay, it is a monoclonal antibody, ends with MAB, so it is a monoclonal antibody which can be added as an add-on to the standard therapy. And this was studied in something called the Bliss trial. Okay, Bliss-LN trial. So these are the updates that I saw in the 22nd edition. So just one extra word about the mechanism of action of Belimumab. Belimumab is an IgG antibody. Okay, it is an IgG monoclonal antibody against the B lymphocyte stimulator, or also called the B cell activating factor. Okay, so by which when belimumab attacks this receptor, binds to this receptor, it leads to the apoptosis of the B cell. Okay, so the B cell are the cell which are dysregulated in SLE, gives rise to a lot of antibodies which go and deposit in the kidney or attack different tissues, the musculoskeletal system, the heart, whatnot in SLE. Okay, so this belimumab is found to be useful in reducing the SLE disease activity index. Okay, SLEDA scores are much less with belimumab. It is a drug which can be given both IV and subcutaneous. Okay, it is an injection. It is either given in the intravenous form or the subcutaneous route. The other update that I saw is there is a paragraph which tells you about the different mutations, the genetic causes of glomerular disease. Okay, when they are discussing the genetic causes of glomerular disease under the pathogenesis, one new the mutation that has been mentioned is the PLA2R GC. Okay, PLA2R GC, which encodes IgG3 subclass of antibodies. It portends a poor prognosis in membranous nephropathy. So in the previous edition, this was not there. So probably this can come as an MCQ in your forthcoming exam.